this webinar. There we go. And so we will record it. This is going to be posted to PAMED's website afterwards for our members to view at their convenience. We also want to thank everybody who submitted questions ahead of time. We've received those questions, and we will take those questions first as we move through our agenda this evening. I will drop the link to submit your questions into the chat. We'd ask that you submit all your questions there. That way we can keep them all together and then we'll aggregate them. If we don't get to questions this evening, we will work with Karen to get those out to the group and to PAMED's membership. We will post the recording, as I mentioned, and then we will also send some follow-up information in Pennsylvania Medical Society's communications. So we look forward to that. I did want to note before we get started too, that we did send an invitation to the American Board of Internal Medicine, ABIM. We sent them an invitation to participate. Unfortunately, we did not receive a reply from them, although we do understand that they are in the middle of a CEO transition. And so we will continue to reach out to them in hopes that we can continue to provide education to our members. And now I'm going to turn it over to Dr. Sandel. I'd like to give a little introduction for Dr. Sandel. As I mentioned, she's currently PAMED's president, and Dr. Sandel is a board-certified emergency physician from Berks County. She graduated from Bucknell University with a BS in chemistry and completed her medical school training at University of Pittsburgh School of Medicine. She completed her residency in emergency medicine at MCP Hahnemann Drexel University in 2005. Dr. Sandel was employed by Tower Health for the past 16 years, initially at Reading Hospital and subsequently at Phoenixville Hospital. Dr. Sandel was instrumental in starting the emergency medicine residency program at Reading in 2018 and was associate director of the emergency department from 2010 to 2019. She also served on the board of directors of the Reading Health System and the Reading Health Physician Group. Dr. Sandel was the chair of Tower Health Partners Quality Improvement and Clinical Integration Committee from 2013 to 2019. Dr. Sandel is currently the chair of emergency medicine at Wellspan Ephrata Community Hospital, ECH. She also was recently elected as the president of the medical staff at ECH. She has been active with us, the Pennsylvania Medical Society, and the Berks County Medical Society since 2006. Dr. Sandel has served on the board of trustees at PAMED and has been the chair of the Employed Physician Task Force and is current chair of Emergency Department Boarding and Overcrowding Task Force. And she also serves on multiple committees with PAMED. Dr. Sandel is the past president of BCMS and most currently served as the chair of the executive committee. So thanks, Dr. Sandel. I'll turn it over to you.
Thank you very much, Allison, and welcome and good evening, everyone. First, I would like to welcome Karen. Thank you so much for joining us tonight. Maintenance of certification has been a leading issue for many physicians in Pennsylvania and across the nation. And we've seen many challenges that physicians have with maintenance of certification. And one of the initiatives for Pennsylvania Medical Society this year is to bring back the joy in medicine and to try to eliminate some of the hurdles and the barriers that we have that are impeding our ability to care for patients and causing more issues with sustainability. So this is a very important issue, not only this year, but in the past years and years in the future. So Pennsylvania Medical Society has a number of policies and guidelines related to maintenance of certification. And we have at least 5 policies that you can refer to on our website, but I did want to highlight a couple of things from those policies. The Pennsylvania Medical Society basically wanted our delegation for PAMED to go to the AMA and request that the AMA's Council on Medical Education update AMA members on any improvements or changes that have been made to the MOC process because of the AMA's policy on MOC and the Council's engagement. we recognize that there's a variety of options to members, and this is one way that we can advocate for our members to do that. We fully support and we shall fully support the concept of viable alternatives to maintenance of certification and adopt the policy, those principles of recertification as articulated in AMA, maintenance of certification, shall support the activity of the AMA as articulated in AMA policy, maintenance of certification, and osteopathic continuous certification. We do have a policy with maintenance of certification statement of principles. Now, there's a number of principles that Pennsylvania Medical Society approved regarding maintenance of certification, and you can refer to those on our website, and we will certainly provide you the link so that you can review those at your convenience. One of the most recent things that we have done is a policy about opposition to maintenance of certification. And I did want to go over that a little bit more closely, that Pennsylvania Medical Society acknowledges that the certification requirements within the maintenance of certification process are costly, time intensive, and a result in significant disruptions in availability for physicians for patient care. Further, PAMED opposes mandatory MOC as a condition of medical licensure and encourages physicians to strive consistently to improve their care by the means that they find most effective. So with that, I would like to introduce Karen Schatten officially. Karen serves as the Associate Director of the National Board of Physicians and Surgeons, where she works to advance science-aligned policies within complex regulatory environments. With prior experience in public policy, planning, and project management, Karen develops strategic policy and growth initiatives, cultivates external partnerships and communications, and leads state and federal advocacy. During her tenure at NBPAS, the organization notably achieved recognition from all major national accrediting bodies for health plans and hospitals, including the National Commission on Quality Assurance and the Joint Commission, further cementing the organization's reputation as an innovative change maker and a positive force for change in the healthcare space. So at this time, I would like to turn it over to Karen to give us an overview of NBPAS before we break for questions.
Great. Thank you so much. Thank you to both of you, Dr. Sandel. It's my pleasure to be here with Pennsylvania Medical Society. I'm very familiar with your policies and statements and positions on MOC, and I really appreciate PA Medical Society's leadership on this issue, and just appreciate you having NBPAS here tonight to answer questions and give an overview. So I'll just dig in and start with a quick high-level history about NBPAS and how we got started. So in 2014, there was growing physician outcry over changes and upcoming and newly implemented changes to MOC programs. And our founder and president, Dr. Paul Tierstein, who is an interventional cardiologist out at Scripps Clinic in La Jolla, California, San Diego area, had a lot of friends simply coming to him and saying, this is not okay. We have issues with this. What are we going to do? And, I love the origin story because Dr. Tierstein said one night he sat down at his kitchen table and he scratched out a plan of what he was going to do. He recruited through his contacts another 19 physician thought leaders, both very notable physicians on the clinical and academic medicine circles. They sat down. Not only did they develop and found a nonprofit called NBPAS, but they spent a lot of time and energy asking the questions of what do physicians really need? What do physicians need to learn to stay current? What do physicians need to stay up to date in their specialty? How do we do this better? How do we do this in a more streamlined manner? And how do we want to change this? And what's our solution? And so NBPAS was born out of those conversations. And they introduced, an alternative pathway to MOC with the goals of being more streamlined, more clinically relevant, specialty specific. And if I had an underlining pen, I would really underline specialty specific. It's a question we get asked really, really frequently. And yes, that's one of our main focuses. And, what really started out as grassroots in nature, and I think there were a lot of naysayers early on who thought we were more of a protest rather than an organization. We've really grown and matured into a respected, recognized, and nationally available certification pathway to physicians. So we're really proud of that. And change is hard. Change is always hard, no matter what field you're in. I think change in medicine is really, really hard too. There's a lot of traditions and strongly held traditions that are hard to sort of, reevaluate. It can be a struggle and sort of a painful process, but I think that there's a lot of recognition of the value now that NBPAS brings to physicians and to hospitals and to patients ultimately. So that's sort of a brief overview of the history. Originally we started out with the goals of being an alternative pathway to MOC, but it evolved. And now in the post-COVID era, our mission and purpose has taken on newfound urgency because of burnout, because of physician loss, because of, serious issues with patient access to care. It's even more important now for physicians to be able to stay practicing medicine. So in some ways, our mission's become more important now than it was even in 2015 when we incorporated.
Thank you. So just a few questions, some of which are more clarification questions. I know you have a website, which is very informative, and I would direct people to utilize that website if they have specific questions that they weren't able to ask tonight. But what is the certification process of the NBPAS?
Sure. So in terms of clinical and professional requirements, we operate on a 2-year recertification cycle. To start with, I think it's really important to say that when our original founding board put their heads together and asked those questions, what's important to making a specialty physician and training a physician, there was universal agreement that initial board certification is key. So our fundamental requirement is a physician must have passed an initial board certification in their specialty. And this is why when I was looking over PAMED's principles on MOC, there was such synergy between your principles and NBPAS's programs, because we believe in it, and it's a critical part of a physician's education. So we require initial board certification without exception. And then when a physician comes to us for a continuous certification, they can only apply if they are already certified in that specialty. And it sounds so obvious, but it's a question we get often. So if you have completed your residency in OBGYN, you cannot come and ask to be certified as a dermatologist, right? Unless you want to go back and complete a whole other residency. So it has to be in your specialty of certification. And then we have a 2-year look back period. So physicians need to submit a minimum of 50 hours of AMA, PRA Cat 1, CME credits. They have to have an active and unrestricted medical license in their state of practice. And for certain surgical specialties, we also have a requirement that goes above and beyond a lot of other programs, which is you have to hold privileges in a facility that has been approved by CMS or one of the CMS accreditors, Joint Commission, DNV, because we feel that if you're a technician and you're doing surgical procedures, that peer oversight is really important as well. So it adds sort of a technical review component to the program. So that's an overview of our programs in terms of the clinical requirements. I think it's worth saying that 50 hours of AMA, PRA, Cat 1, CME is the floor, not the ceiling. And I wish you could see what we see every day on our end, because sometimes our credentialing side, the physicians will submit hundreds and hundreds of hours of credit. The reason we picked AMA Cat 1 and we only accept AMA Cat 1 is because it's the highest level of rigor. It is fully accredited by the ACCME. And if you look at AMA's statement on what PRA Cat 1 is, and if you look at ACCME's statement on what AMA Cat 1 is, these are CMEs that also have requirements for practice improvement, quality improvement, measuring learner change, and they're the most rigorous. So those are our requirements, and we don't diverge from that.
Now, when you're talking about CME, does CME have to be related to your specialty of practice?
Yes.
And yes. Are there physicians that, work for your board that are the ones that are doing the evaluation of the validity of that CME?
Sure. So great questions. So first off, yes, probably one of our most common questions, the CME you submit has to be in your specialty. So, I'm not a physician, but when I look at CME that's available online or live or anywhere you might pick up AMA Cat 1, there are a lot of really interesting CMEs that teach you about being an administrator or teach you about wellness or teach you about mindfulness. But if you're coming to us to certify, let's say Dr. Sandel as an emergency medicine physician, it must be in emergency medicine. And so our physician board is volunteer. They're entirely unpaid. I like to tease them every Christmas that we're going to give them a raise. We're going to double their salary, and the joke never gets old for me, at least. But so our physicians are not involved in the day-to-day operations, but we have a dedicated team that does hand check and verify all CME credits, and they're very, very highly skilled at this. So any CME that comes in, not only does it, I don't know how familiar you guys are on the sort of the CME submission side, but ACCME, which accredits all CME in this country, or largely credits the lion's share of it, they have specific reports that they can populate for the physician. And so we ask physicians when possible to populate those accounts. And so we can actually verify, it's called CME Passport, and we can verify some of those credits. So it's all hand checked, it's all hand verified. We are not shy about rejecting credits if they are subpar, not related. We'll tell a physician, sorry, you're X number short, need to come back. But the vast majority go well above and beyond those numbers.
Thank you. Mm-hmm. As far as you mentioned, that one of the, I guess, pillars of your program is that you need the initial certification, which means, if you've already sat for the test in your specialty. Are there any other tests? I know that's a thing that comes up many times with our physicians that, their boards that they're currently, boarded under, have a test every 10 years, or they have tests yearly. Is that the case with your program?
So it is not. And again, going way back to 2014, when our board got together and started looking at the evidence and saying what's evidence-based and what's not. And what became clear is really good, strong, solid support and evidence to defend and always require an initial board certification. Unfortunately, MOC has been around for 20 plus years now. And over that time period, regardless of the format of the test or the type, be it the 10-year, the 5-year, the 2-year, the all-year, the multiple choice, the closed book, the open book, the timed, the more time, there's just no data to this point. And when I say there's no data, there are a lot of people who study this and publish data, but when I say there's no data, there's no high quality data that really, in our position, in our opinion, can really, that has enough value to defend the cost and burden of requiring MOC. We do believe in competition and choice. So we do think if a physician happens to love it and that's the way they choose to study, that's fine. But we also do believe there should be competition and choice, and those physicians should choose. And very much like PA Medical Society, we believe that a physician's initial certification is lifelong and should never be removed, which is not, unfortunately, the case now. MOC is not really a voluntary program unless you're part of the cohort of physicians, the older 40% of physicians who was grandfathered or exempted from participation at the time when MOC was put into place. And, going back to some of the original, sort of an overview in history of like, why were we founded in the first place? I mean, I think there were 3 or 4 main problems that our founding board, sought to remedy. And one, I already talked about creating an alternative and less burdensome pathway to MOC. There were also 2 areas, I'll say 2 areas of conflict of interest that our board was concerned about and continues to be concerned about. One relates to profit and dollars. And so they felt there was a conflict of interest if a board was selling and profiting off of a product and saying this product is required. We also make a lot of money from it. It represents a conflict of interest, perhaps, and especially when the evidence wasn't supportive of that pathway. And the second conflict of interest of concern was evidence itself. And there is a lot of, some of the studies cited we feel are, have authorship paid by the organizations, again, who are putting out some of these mandatory MOC programs. So again, conflict of interest on the financial side, conflict of interest on the evidence side. So they really wanted to, we don't make money. We don't sell anything. We don't sell CME. We simply certify physicians who present and, they present their ongoing lifelong learning to us, and we certify and attest that they are doing what they should be doing. Okay. Along that point, some physicians say, or some critics may say, well, how is that different than state licensure? And actually it is quite different because, as many physicians know, very often depends on your state, and states do vary, but many states just ask physicians, have you done your CME? And it is literally an attestation checkbox, whereas we hand check and verify credits. But the second part of it is, even if on face value the number of CMEs that we require and the state require look similar, if you go a little more granular, take a deeper dive on what those CME credits from state requirements are, many of them have a much lower threshold of AMA PRA Category 1. So physicians might be allowed to submit Category 2s, and there may be the credit pool, if you will, is further diluted with things like, it could be opioid training or child abuse training or infection control or diversity training. The state of Texas, you even have to pass a law exam to be licensed in Texas. States have a whole variety of very different requirements that are not specialty specific learning. So, our position is we're happy that the NBPAS model supports what physicians already have to do for their state, but we want to ensure that there's a really robust number specifically on the clinical side. And that's, we revisit it from time to time. We get suggestions from physicians all the time, really. But until there's data that tells us otherwise, we are solid in our model, in our program.
So a question that I have, and this doesn't pertain to me. I'm only boarded in one board, the emergency medicine, but those physicians who are have multiple boards. So, they may have an internal medicine and then they go on to do critical care and maybe sleep medicine. So perhaps 3 different boards. How do you deal with that in your organization?
That's another great question. So I was going to say it's similar. It's not quite similar, but we look for evidence of, if a physician says, I want to be triple boarded, then we require evidence and credit submission from all of those specialties. Very often, I shouldn't say very often, but sometimes a physician will say, well, I like to use sports medicine, actually. PM&R is a great example because there are a lot of sports medicine physicians who 100%, all they do is joint injections all day and they, dealing with athletes, and they really don't use their family medicine training if they've come up through that pathway. So for those physicians, they just say, I'm not going to recertify in family medicine. I don't need it. It's not my practice. And I'm only going to recertify in sports medicine or PM&R. Other physicians do. We have, in fact, I think one of the best stories I ever heard was an oncologist out in a rural area out in the Northwest, and she was the only oncologist covering 3 different states in a very rural area, and she was boarded in, I might mess this up, but it was probably internal medicine, oncology, hematology, possibly hospice and palliative care. And she said, I couldn't afford to do this, and I could not take care of my patients if I had to do MOC in all of these programs. She said, but with NBPAS, I keep up with my CME in all of these areas. It's what I do. It keeps me current. And this was in an area where there's a, really significant need for coverage. So I think we still require evidence in all specialties, but it seems to serve our physicians, in a more, a less burdensome way.
Now, you mentioned that, you've been in business since about 2015 when you were formed. And do you have, and you mentioned it's very difficult to find outcomes for maintenance of certification. But do you have any idea, do you have any either data or any idea if this is working, or is there any outcome data? How do you know that someone, is still able to practice in that specialty other than submitting CME, or as you mentioned, in some of the procedural areas, getting that verification from their hospitals or health systems?
Sure. Yeah. Well, there's a couple different parts to my answer. And the first is, yes, there is data. So if I was presenting my typical slide deck tonight, I run through a bunch of data slides, and there are some really large studies, and I can share them with you guys post chat. If you wanted to distribute them to your members, that would be fine. A lot of the data comes from, there's some large VA hospital pools with tens of thousands of physicians. There are some Medicare, people looked at Medicare claims, over 2 million patients. The Medicare data of 2 million patients pertain to infections and complications from elective surgeries. And luckily, the studies happened at a time when the MOC and the grandfathering began. And so you have these wonderful cohorts, wonderful in terms of research data, of physicians participating in MOC and physicians not participating due to grandfathering. And the punchline of every single one of those studies is no difference in the outcomes and surgical complications. Another one of the studies looked at the top 10 sort of primary care performance measures, things like A1C, if you have diabetes, certain measures that are just sort of basic quality indicators. Again, no difference between cohort A and cohort B being MOC and versus no MOC. So, and those were the studies that our board leaned heavily on when they were coming up with our programs and requirements. So yes, there is. The second part of my answer, and I've heard this directly mostly from physicians who say, my hospital knows everything about me now because we live in the digital era. And so they know every patient that has an infection. They know how many cases I'm reading, how many patients I'm seeing, how many tests I'm ordering, which tests I'm ordering. Are they appropriate? Do they follow the guidelines? Do they not follow the guidelines? And so we are lucky in a sense that there is so much oversight. Physicians are measured and monitored more than ever before. And most physicians now work for hospitals and health systems. I think the stat is, you can correct me if I'm wrong, I may be a little bit off, I think it's about 80%. And that number is expected to grow, and we won't get into that debate, but I think the point is that there's constant oversight, constant monitoring, and constant data evaluation. So I think that there are many, many pieces to physician evaluation. And NBPAS also believes that board certification is just one. It's not supposed to be the end-all be-all of whether a physician should practice medicine. And there are plenty of physicians who have, participate actively in MOC who may not be great with patients. And so that's where the employers come in, and that's where the oversight comes in, and that's where medical licensure comes in. So there's all these different pieces that feed into a bigger picture is what we believe.
Thank you. We did receive a question. It's very similar to the discussion we're having now from one of the physicians prior to the webinar. And I did want to ask this specifically. Do you have any data available that looks at practices, skills, patient outcomes between physicians certified through the NBPAS versus other maintenance programs or other types of certification?
Sure, yeah, great question. I've heard our founder, Paul Tierstein, answer this a lot of times, and he usually chuckles and he says, "We don't, and it would be impossible to get." He's like, "I don't know. I don't know how we'd get that data. Are you going to blind physicians? Are you going to take a group of physicians and say, for the next 20 years, you do this, and for the next 20 years, you do that?" So that's one very difficult aspect of implementing it, of trying to get that kind of data set. But the other issue is, oh, I lost my train of thought, but that's that's one of the biggest issues. I don't know that you do. Oh, I know what my second point was. The other issue is that MOC is constantly changing. And so which I always like to say, which MOC are we comparing it to? Because even if you look at some of the websites, they're confusing to me. I'm not, I'm not actively participating in them, but this year you do this program. This year we're transitioning to this requirement. Next year it's a different requirement. So, critically speaking, I would step back and say, how are we going to evaluate data on MOC? MOC is a general term, but not only does it change, does it seem to change frequently within programs, there's also 24 medical specialty boards that all do something different. And so it'd be really hard, really difficult to nail that down. If someone can think of a great study, I'm all for it, but Dr. Kirstein came up, wasn't sure how to study that one.
Related question, as far as physician input and suggestions. So have you had feedback from physicians that have been part of your program over the last 9 years that has changed the way that your program has offered maintenance of certification, similarly to some of the more traditional programs that we might be familiar with?
Sure, yeah. So we operate a little bit differently, as far as my understanding of other boards. And we have an open door policy, not a literal door, but our info email box is an open door for suggestions and comments. And we receive, we're in constant communication with our physician diplomates. We get ideas all the time. And sometimes if there's a good idea, we implement it. We're implementing one right now on the operations side. Someone gave us just an absolutely fabulous idea, and we ran it up the chain and vetted it, and we said, this is terrific, great idea, and we're going to implement it. So we're not, we're always open to suggestions and criticism, and people have suggested we don't have a stringent requirement for initial board certification, or we change our requirements for foreign medical graduates, or people come to us with different stories and different circumstances, but there hasn't ever been anything really compelling on the clinical requirement side that our board has, made any significant changes to that, particularly when it comes to initial certification. I always, it's not non-negotiable. So.
I wanted to kind of pivot a little bit and talk a little bit about data. And since you don't have your traditional slide deck that you use, I just wanted to go over how many physicians are currently participating in your board certification program.
Sure. We currently have over 14,000 physician diplomates nationwide. We certify physicians in all 50 states. There's a little over 250 in Pennsylvania right now. And when I asked our team this morning, I think we have somewhere between 5 and 10 new applicants in the pipeline from PA this week. So very excited to see that. Sometimes we're asked the question, like, what states accept you, or what state governments recognize you? And I always, the answer is, states don't recognize board certification. So generally speaking, with one very small exception, states don't require board certification for licensure, which we agree with and think it's how it is and how it should be. So states don't really weigh in on this issue. There's many layers of government involvement in medicine, but states don't really take a stand on board certification. And again, generally speaking, with very limited exceptions. So it's not a matter of states accepting or not accepting. This might be a good little time for me to pivot over to the payer side, which is another question we get very, very often. And people will ask, well, which payers accept you? And give me the list. And so the answer is, we don't maintain a list, and here's why. you have to step back for a moment and understand what the national accreditation standards for health plans say. And what they actually say is that board certification is not required. And that usually surprises a lot of people, right? What it says is if a physician is board certified, it must be verified at a primary source. So, for example, the primary source of board certification data for initial board certification is from ABMS or AOA, because they provided the certificate, they tested the physician, that's the primary source. The primary source for medical licensure would be the individual state. So you have to verify qualifications at a primary source. And that's, I can assume simply because we don't want fraudulent physicians people claiming fraudulent credentials that they don't have. What it further says about payers and health plans and board certification is that hospitals or physician employers are the ones empowered to decide how they want to credential their physicians. So it's a common misunderstanding. People think that payers get to tell the hospitals what to do. In reality, in most cases, and again, there's always exceptions, but in most cases, the hospitals actually get to dictate their credentialing standards to the payer. And then they write contracts based on what those credentialing standards are. And so what this means for NBPAS and what it means to physicians in Pennsylvania is the important question is actually to have the conversation with your hospital, with your MEC. So like Dr. Sandel, you, for example, your chief of staff, you would be the first person I'd want to speak to if I was a physician at your hospital. And I might come to you and say, hey, this is really interesting program. I've decided to certify with them. What do you think about adding NBPAS to our bylaws as a accepted form of continuous certification? And typically what happens, we have 200 hospitals of record, 200 plus hospitals of record who accept NBPAS. It usually ends up being a discussion with the MEC. There's a vote. There's an very simple addition to the bylaws, and then physicians may choose their continuing education and lifelong learning with NBPAS. So, I always tell physicians, go to your hospital. Your hospital is the important conversation to have. It's pretty hard to chase payers down which sell tens to hundreds of different insurance products. It's a very complicated, sticky wicket where you'll get lost in the woods pretty quickly. So the conversations that physicians should be having about NBPAS is with their medical staff, and that's almost 100% of the time how hospitals organically end up adding NBPAS to bylaws. Does that make sense? It's a little bit of a surprise.
It does. And I think we have a couple, of questions that came in regarding that, because we've had physicians that have asked the question, I'm boarded by NBPAS and my hospital currently accepts that board certification. However, maybe I'm transitioning to another hospital that does not accept that as a certification as per their bylaws. So when do you have to disclose that in the process of transitioning to the hospital, and how do you advocate as a physician or as a group of physicians that the hospital amend their bylaws? We all know how long that takes as physicians. It's like glacial pace to amend bylaws. And so, how does one go about that? And what's the risk of a physician if they do, use alternative maintenance of certification and now are in this situation where the new system does not accept that?
Sure. Yeah, there's a couple parts to that question. I guess first to the part of, do I drop my other board and do I want to be NBPAS only? And the answer is always that's a very personal decision that every physician has to make for him or herself, depending on their circumstances. And if you think you're going to be in a different job every 2 years and you're not sure, and NBPAS is still growing, in your region, it's up to a physician. We have about, I would say we have a good portion of physicians who choose to maintain two boards, NBPAS and a traditional board, while they're, while we are building, our scope of or sphere of hospitals, and others that just feel very comfortable dropping their other board and certifying with NBPAS only. So it's a personal choice is answer number one. To the point of, so how do physicians do that and how do you get bylaws changed? Some hospitals, actually, it happens very quickly and easily. I know that that might not be hard to believe. It probably depends on the size of your hospital, the openness of any particular MEC to change. But we have all sorts of materials on our website, and we do directly support physicians as they're working within their hospital or health systems to help have those conversations. So we have all kinds of templates and bylaws, and to try to start those conversations. Sometimes MECs have lots of questions, very similar to the questions we're getting here tonight. And so we will go in and present either, rarely in person these days, but often virtually, to hospital leadership or MECs to answer these questions. And then, most of the time, once those questions are answered, very often NBPAS gets added to the bylaws. So that's the process. In terms of sort of the bigger picture, how are we advocating nationally? And I like to say that, my job and our job is to remove all these barriers so that physicians don't have to jump through hoops. Nobody wants anything to be harder in their day. So, on the larger scale, we were working at the highest levels of, government and policy making to educate and advocate, because, if you ask me what our my vision was, would be for 5 years from now for NBPAS, I would be very hopeful that it would be, very well known, respected, understood, and nearly universal. And I have a friend over at Geisinger Medical Center who's in the administration there, and he's a DO, and notably, Geisinger Health Plan was an early adopter of NBPAS. They were they vetted us very thoroughly and officially added NBPAS to GHP bylaws. But one thing he said to me as an osteopath, he said, "This reminds me so much of DOs, 30 years ago, when people were very afraid and really were not, we weren't finding many open doors, and we had to knock loudly and frequently." And so, he gave me a keep up the good fight message, but I think it's a good analogy. I think new, change, different, it takes time, and we're working as hard as we can to, have conversations like this, which really go a long way to educate and hopefully get a lot of questions answered.
You had mentioned that over 200 hospitals currently accept the NBPAS means certification program and physicians associated with it. And you have an extensive list on your website of those hospitals. Now, since we're in Pennsylvania, and I noticed that in Pennsylvania, there's only 4 hospitals listed. Have you had conversations with other hospitals and health systems in Pennsylvania? Are there ongoing, without naming systems or hospitals, have you had those conversations? Have there been any barriers that you've noted to bringing your maintenance and certification program to those hospitals, or what can physicians kind of do?
Sure. No, good questions. Typically physicians broach those conversations themselves first. No hospital, it's physicians will sometimes say, "Well, come in and convince my hospital." And my answer is always, your hospital is not interested in hearing from me. Your hospital might be interested in hearing from you, right? It has to come from the medical staff. So I think, without naming names, there's a couple very well-respected systems, large systems in PA who I know are very favorable to NBPAS. And, there is a time there, everyone has to talk through and vet. I think the larger the system, the longer it takes. But I would say, yeah, I'm not sure I can answer the question. I don't have a crystal ball, so it'd be hard for me to say exactly why. But I know, we're experiencing a lot of growth, even at academic medical centers. And one that comes to mind is just over the border in New Jersey, Hackensack Meridian Health, which is a 17 hospital system with academic affiliations. And that was a terrific. It's a terrific group of facilities. And there's a lot of interest in rural health, and Pennsylvania has a lot of rural health areas here and underserved areas. We've just added a number of big systems in Texas that specifically serve rural and underserved populations. So I think there's a way to go. We have opportunities in Pennsylvania. Frame it as an opportunity, and the more physicians who join, truthfully, the faster it happens. And there's always a chicken and egg sort of process or question here. And if I could, if there's only one thing that anyone remembers, after this webinar, I would say it's really important if you're a physician who, believes in this idea, this concept, and really appreciates what NBPAS is doing. It's really important to certify, even if your hospital doesn't accept yet. And we do get those calls where they'll say, well, I'll certify as soon as my hospital accepts. But in reality, what we find is hospitals are much more likely to listen when they have 10, 15, 20 physicians, really well-respected physicians on their staff who come and say, hey, this is what we're doing. We should take a look at this. That's usually how change happens. So I always say there's really two components at this point in time. There's a certification component. We really care about your learning and your what you're staying current on. And then part two is certification is a point of advocacy, and it does help build NBPAS, and it helps us grow, and it helps build awareness. So if nothing else, certainly encourage physicians who are interested to apply and certify. And that would be the fastest way probably to grow hospital acceptance in Pennsylvania.
Well, you answered my last question I was going to ask before we open it up to questions from the participants, which was, just the three main reasons that you would recommend that physicians certify with your board. And so with that, I'm going to ask Allison and Leslie to see if we have any questions from the participants that we can share.
We've done a couple, those are kind of all clustered.
Okay.
And then there's one more on the next page.
Okay, great. So some of the questions from the participants: what advocacy efforts would be helpful for physicians to do for NBPAS?
Oh, it's a great question. So we have an advocacy page, a take action page on our website. So you could start by going to our website, and maybe Allison, I'll ask you, that would be a good moment in time to drop into the chat. We have a general email info box, info@nbpas.org. And you can send us questions, and we can send you resources, but also feel free to go to our website, which is simply nbpas.org. And we do have a number of advocacy resources. A second thing that's very, very important in real time, actually, I don't have the link. I should have thought of this in advance, but I could probably find it quickly. There's a joint effort among three large federal agencies: the FTC, the DOJ, which is the Department of Justice, and HHS, the Departments of Health and Human Services. And they're taking a really close look at areas where competition may be stifled and where certain organizations may hold a monopoly and harm competition. If you do a Google search on FTC, DOJ, HHS, healthcare monopolies, you'll find a link to their portal, and they're looking for public comments where people can talk about any problems they're running into. And we've had many, many physicians comment about the monopoly that ABMS holds on certification. And it's really, really important opportunity to have your voice heard, because I think there's so many issues in healthcare, and there are so many fires that need to be put out. And it's easy to sort of turn to the biggest fire. And so to make your voice heard on a much larger scale, I would really encourage physicians to find that portal and submit comments. And that will really help NBPAS as well, because it's hard to compete if you're not on a level playing field. And so that's something you can do. And again, go to our website, look at our resources, take action page. We'll always keep that updated with opportunities that are happening in real time where we might need physician input or comment. But again, certifying and joining us and adding your voice and starting to have conversations with your hospital, boots on the ground, is always really appreciated.
You just answered 3 questions that we had in one answer. So thank you very much.
Sure.
Here's another question that comes up, and you'd mentioned the osteopaths and osteopathic physicians. And one of the questions was, I'm a DO. So can I get certified as a DO through the NBPAS? And I think, also, looking at that, is there, do you have a lot of in your data of your physicians that participate? Is there a good mix of MD and DO? Is it, allopaths, more osteopaths?
Yeah, I would say in terms of data, we definitely have more allopathic physicians, but I think that also simply reflects the population of allopaths versus osteopaths in the general physician population. But absolutely, yes, we certify DOs, so please come and certify. And the requirements are the same. We look for initial certification, and then all the other requirements that you'd have to meet. But absolutely, we welcome DOs as well as MDs.
Thank you. And let's see here. I think you answered the next one. The one question that came in was about CME activity. So say that, again, we're going back to the person who's triple boarded. So say there's a CME activity, but it might qualify for 2 or 3 different board certifications. Does that count for all 3, or do you have to have like 150 separate CMEs to get board certified in each one of those areas?
Right. Good question. Do you mean, just to clarify, do you mean that let's say you go to a conference, I'm going to make something up, it'll sound wrong. But the CME will actually grant you credit. They'll say this will count towards internal medicine and pediatrics.
Yes.
Okay. Yeah. So we count numbers of credits. So how do I explain this? So no, if you're triple boarded, it's not 50 per specialty, but we need to see evidence of all specialties, if that makes sense, which is actually, to my understanding, a little bit different than some of the other boards. I was on actually just ABIM's website earlier just to make sure I was educating myself properly. And if I understood the website properly, it said we no longer require physicians, if they maintain a specialty, a subspecialty board, that we don't require them to maintain the, I don't know what you'd call it, the original board or the specialty, the original sort of underlying specialty board. And I don't want to speak out of term if I misunderstood that, but if I understand that correctly, it sounds like they don't require, let's say, internal medicine if you're going to maintain your specialty in, what's, perhaps
cardiology or whatnot.
Yeah, cardiology, hematology, exactly. So we're a little different, and we do want to see credits in each specialty area. So, if you want to be triple boarded, we're going to need to see evidence of that and of learning in all 3 areas.
And is it 50 credits for each one of those areas, or is it just 50 overall?
It's 50 overall. It's as a minimum. And again, especially when we get physicians in like that who are triple or quadruple board certified, very often we have submissions of 200 plus credits, over certain time periods. So we often get a lot of credits.
And adding to that, is there an extra cost to maintain all 3 boards, or is it one price for all 3? Is it a special? Do you offer a special?
Yeah, every physician should go out and certify with as many boards as they can, and then come over to us. So our cost is fixed. So whether you're single, double, triple, quadruple boarded, the price doesn't change. It might be helpful to say what our pricing structure is. So we charge $189 every 2 years, or it amortizes out to $94.50 per year, and that's regardless of the number of boards that a physician certifies in. So if you compare it to a typical MOC program, I just want to maybe throw in there, we charge no late fees. We don't penalize anyone for any reason. We're very happy to welcome our physicians. But if 99 every 2 years. I lost my train of thought. But if you compare our prices, sort of it's not exactly apples to apples, but if you take a price of an ABIM MOC and you add on one subspecialty, on average, NBPAS is about 72% cheaper than other maintenance pathways. And I think that's important for a number of reasons. There's the direct costs. So there are direct costs to physicians that are saved. These are also direct costs that are saved by hospitals or health systems, because so often they are providing the funding for physicians to do this learning, and hospitals are strapped just like everyone else in healthcare is strapped. So it's a savings to the individual physician. It's a direct savings to hospitals if they reimburse. There are also lots and lots of indirect costs in time away, time lost, etc. And so, we feel that there's a lot of savings, both directly and indirectly. And ultimately, what do we want to do? We want to keep physicians current, but we also want to keep them in medicine and make sure they have time to be seeing their patients. So I feel like that's a win-win on the cost side.
Now, you had mentioned this earlier, but that there were no specific requirements for the state-specific licensure CME. So what happens if a physician does get the CME in their specialty, but doesn't meet the CME for the state licensure requirements? Do you have any, are there any ramifications because of that?
So let me just clarify. So states do have specific CME requirements, but they often are, in terms of the AMA PRA Cat 1, they often shake out to be less than what NBPAS is required. So let's just say a physician, I'll call this fictitious physician, Dr. Smith, comes to us and they've done wonderful CME, but for some reason it doesn't meet their licensure requirements and they don't have an active license in place. We couldn't certify them. The licensure piece is a really important component of professionalism. I can't really think, practically speaking, of a scenario how that would happen. I guess how it could happen is they could have their Cat 1 CMEs, but perhaps they didn't do their other modules required by the state, and the burden is on the physician to to make sure they're meeting all the requirements. So I don't know that it's ever happened though. So
two more questions, and one is, if a physician is credentialed through your board, are there credentialed letters that would go behind their name, for that the identification?
Yes, there are actually, and we encourage our physicians, both in their professional lives, on social media. What they write is D, so for diplomate, and then NBPAS. So they write diplomate of NBPAS, and they add it to their signature block or wherever else they want to do it. And there's also a certificate. We do offer printed certificates for framing and hanging on your wall, etc.
I just have one last question. And again, you have a very specific website on the requirements for certification. Is there anything that would negate the certification? So disciplinary, obviously if someone doesn't keep up their license, but are there other things, code of conduct issues, anything else that would essentially remove that physician from certification?
Sure. Really good question. And really, I know it's a hot button issue for a lot of people, not just in Pennsylvania, but nationally. So our position is that, our job is to certify physicians' competency and professionalism. We weigh in heavily on the competency and clinical side. We rely on proof of licensure for the professional component. So if a license is restricted or not active, they cannot certify with us. We do check, a physician has to renew on a 2-year cycle for many reasons, but one of them is we need to verify over a certain period of time that there have been no licensure actions. So even if a physician seems to be practicing competently in their job, but there is some sort of complaint or problem on the licensure side, that would hold up and prevent us from recertifying them with NBPAS. In terms of, we do not require a specific code of conduct because we feel that all the state medical, if you look at any state medical board, they all have very, very clear code of conducts. And, in terms of, they actually have they're empowered. It's almost, how do I describe this? States are given the statutory authority to ensure that physicians are appropriately practicing medicine in the state. If there's a problem, there's due process, there's a hearing. Physicians are allowed to defend themselves with attorneys. And we feel like that's the appropriate pathway if there's truly a conduct issue. And we think state medical boards actually do a good job of that. So that's their lane, and that's why we require it, because that gives us that element of confidence of the state licensure component. And we stick to our, certifying the clinical competence, which is our lane. When you put them together in the big picture, you get competent professional physicians. So again, I can't even think about, we certainly have not been able to certify physicians, often on the licensure side. And we just follow our model, and it's worked really well.
Karen, thank you so much. And just from my standpoint, before I turn it over to Allison, I'd really like to thank you for taking the time tonight to meet with us in Pennsylvania Medical Society, meet with our physicians, and in line with our policy and guidelines, to take a look at different ways that we can maintain certification and take a look at different avenues that physicians may have now and in the future, so that we have a choice, and that, as part of our policy, that we're able to do it in the way that physicians want to do it, and not the way someone else is making us do it. And I'm hoping that this will help to bring back joy and sustainability in medicine. So I'm going to turn it over to Allison.
Couldn't have said it better. Just want to thank everybody for coming. Thank you, Karen. Thanks, Dr. Sandel, for moderating. And appreciate everybody who submitted questions. We will be posting this to our website and then follow up with some follow-ups in our PAMED communications. So thanks, everybody. Appreciate your time.
Thank you.
Bye-bye. Good night.